Folks, we're back. We're at Sycamore Crossing, downtown Blue Ridge. It is time for Ask the Doc with Dr. William Whaley and Dr. Raymond Tidman. I hear the train.
Yeah, but they just missed the bells by about a second.
Huh?
They missed the bells.
Well, you know, I'm getting to the point where my bells ring twice, so you never know. We might have them again, right?
You got to quit talking.
Am I still hearing the bells?
You gotta quit,
Doc,
you got to quit talking back to your wife.
Hear me.
Listen, I want to say something else. What's the day today?
Friday the 13th.
Yeah, it's Friday the 13th. We're turned around a little different today because it's chilly in beautiful sunny Blue Ridge. But you can see my truck. You notice the red truck?
I got it.
Okay, this is Bait, that truck. It sits out in front of the shopping center, and every weekend, women, children, all get their pictures taken with it, and they get in it and everything. So this is a typical vehicle for Blue Ridge, Georgia.
Okay, well, we'll get to you in just a minute. You just hold
I'm just
tight
chilly,
over there.
that's all.
No, I want to know the tie. There's a whale on the tie.
Okay, well, you know, that was my nickname, Whale. No, it says Whale on the, what's it say on the license tag of that car?
Whale.
Whale, yeah, that's my nickname from way back. I just got back, you know, from a week with the guys who graduated from high school with me in 1958 that are still able to stand up and carry a golf club. And they, so seriously, they were down to 11 of us. There were about 50 of us.
I was going to ask how many.
I wasn't.
There were 11 of us. There were 50 of us 6 years ago. But anyway, they said, Whale tail. You still got that on your license tag. That's what they named me in 1952 football team. I mean, Whale tail. I used to say you can't drive a railroad spike with a tack hammer. You know, that's how that came around.
We always thank Georgia.
Enough of that, huh?
We always thank Georgia Cancer Specialist, Northside Hospital Cancer Center. Just a brief minute, sir. You may have to, you know, come a little forward.
Hello.
If we have noise in the background.
If you're going to be heard.
Yes.
All right,
okay.
Let's go here.
Let's get started,
All
Dr.
right.
Whaley.
Interestingly enough, these questions are going to have some psychosocial thing to them about Ray Tidman's thing, the sky is falling and people are making a big deal out of a molehill. But the first one is a real thorny question for this family. My father is 75 years old and has colon cancer metastatic to his liver. Now, it's just been a couple of weeks ago that we had a case like this where it was one spot and they were going to remove that spot after chemo and the cancer, and we gave this guy a good chance of long-term survival, right? So we're going to hit a few of those, we'll pull back a few of those slides here in a minute. Metastatic to his liver. After 4 months of FOLFOX chemo, his liver is better on PET scan. The PET scan, however, showed bilateral lung infiltrates, and he was very sick with fever, a white blood count, high white blood cell count, and coughing up huge hunks of junk. Now, Ray would say, this guy's got pneumonia, right? Sounds like he's got pneumonia. The oncologist held his chemo and sent him to, did you read that? An obnoxious young pulmonary doctor who said, quote,
I don't know that specialist. I've never had the doctor say, I want to refer you to
an obnoxious young. I didn't know, I don't know who that one is, but FOLFOX is killing your father and he must stop immediately. Well, I can tell you right there, physicians don't do that. They may say your dad may have some reactions from his medication or something like that. Right, Ray? I mean,
I do
good
want to
physicians.
They're not going to be.
Good physicians do not do that.
Yeah,
I want to share with the audience that our question here, when they, after obnoxious young pulmonary doctor who said FOLFOX is killing your father and stop it, that's in capital letters. So in our world, that's just really
loud. Yeah.
Yes, it got a little loud right there.
Well, here's the next thing now. He gave no explanation. And antibiotics and steroids that he gave him cleared Dad up, and he no longer has high fever, high blood count, or sputum production. So he had pneumonia, clearly, and he got better. The oncologist suggested pushing on with chemo. I mean, after all, this is cancer you're treating, not athlete's foot, without the oxaloplatin, and said that the PET showed improvement, so he'd done well on that drug, and it was okay to start maintenance therapy. What do you say? Now, we have had a lot of talks here about chemo kind of get your arms around the disease and then try to come up with something that's less arduous, less hard to give, or less toxic to maintain that remission. When you're not in the situation, or like the previous couple weeks ago, when we're going to keep the high dose medicine up until you got the maximum response, because we're going to go in there and surgically remove it. So that's a different concept. This concept is to extend useful, productive life without hurting him too bad. The other one is you've got curative intent. Palliation versus curative intent. Go ahead, Ray.
Well, I would use it's interesting use of the word obnoxious. I would say obnoxious is the young physician not calling the oncologist.
Yeah.
And talking about, well, how can we manage this patient?
Yes, that's true,
obnoxious.
Too.
All right, let me stop you there, okay? So we know on our side of the fence, is it common that you have a patient visit you and they're talking about another physician? Is it common to go back in the office and pick up the phone?
Oh, absolutely.
Is it?
You look at good physicians, yes.
It's common to
that's
pick up.
what good physicians
And say,
do.
I just had your patient here?
No. Right during the visit. If you look at my telephone, I've got 3 text messages I sent yesterday during a visit.
Right during the visit.
To talk to the doctor and either learn what they were doing or tell him what I was doing. One or the other. Yeah. Okay, let's go ahead, because this is really interesting. Okay, so put up the first one. First one says, when colon cancer spreads to your liver. Now that's a pretty bad sign. We went over this a couple of weeks ago with curative intent. So we didn't show this one, but we did show the next one. So pull the next one up. What this says is that this colon thing has spread to the liver. Remember, this one we used a few weeks ago because that lesion in the liver and that lesion down there were both going to be removed. I can tell from this, you can pull that one down, that this man has more than a easily removable spot, or the oncologist would not have taken the stand that he took when they got to this point. What's that there?
Algorithm.
No.
Survival curve.
There you go.
Survival
All
curve.
right, survival curve.
Survival curve.
This is the difference. Wait, I don't know. There's a top and there's a bottom, right?
Mm-hmm.
Okay, the top one is when you've got the 1 or 2 metastases you can remove, and this one is where you don't. But if you still look here, you've got people that are living out here 5, 6, 7, 8, 10 years that are up around, what, 25 or 30% if they are appropriately treated. Well, that implies,
Now we have an algorithm.
that implies maintenance. Now, we've got this algorithm, and we're going to spend a little more time on this one than we generally do. Got the algorithm up there. People don't have to be able to see this because it's hard. But when you're starting up here and getting through this is all of these genetic tests, so that the therapy for people who get down this right-hand, this is, I guess it's the left-hand side, just when you look at, anyway, the left-hand side of this thing down here, they are going to be getting the targeted therapies and not chemo. This guy is on chemo. So that means he doesn't have 97 of these other things that make it happen. So when you get over here and you come down this page where you get to chemotherapy, every one of these chemotherapeutic regimens, 2, 4, there's 7 of them here, 8 of them here, all of them include the drug oxaloplatin. Now pull that one down. So the issue here was that the pulmonary doctor said, this regimen is killing me. He did not specifically say oxaloplatin. He might have, but she didn't bring that up. But if you take a quick look, I'm going to show, this is just a chart. When you look at a quick look, there's only 2 regimens that are effective in colon cancer that don't include oxaloplatin. The other 9 have all got that drug in them. Pull that one down. So what we are focusing our attention on right now is the statement that Folfox is killing your father. That would be oxaloplatin.
Mm-hmm.
Pull the next one up there, your picture. This is a really interesting drug. Got the picture? You'll remember, no, you won't remember, Ray will. Way back, I'd say I entered practice in 1972, and I was probably 1980, the drug cisplatin began to come out. You can pull that down. That drug is a very effective drug, particularly for lung cancer and other cancers, because this is lung, cisplatin. But it made you really hug the toilet. It was bad for nausea, and these nausea drugs came up to make that better. Oxaloplatin happens to be a very similar drug, much less infusion, nausea, and so forth, and equal or better effect. Now, when we're talking about cancer research, we're talking about thousands of patients when you file for the ability to use these drugs. So this is oxaloplatin chemotherapeutic side effects, and close to, you got them up there, that next chart, close to 1,000 cycles of chemotherapy. And there are things that occur as frequently as 30, 40, 50% of the time. Well, what is it going to occur? What's going to occur 50% of the time? You're going to drop the blood count, aren't you? Some populations going to be transfusion. So everything up here that occurs 50, 60%, but people who lose their appetite, 2, vomiting, 2, allergies, 1, tingling of the fingers, everybody gets that with oxaloplatin. But if you look at that long list, there's no pneumonia, there's no interstitial fibrosis, and there's nothing that this man had that's on this list. Pull it down. Now, I've said many times, if you go, when you pick up your drug from the pharmacy, if you pick up ibuprofen or Advil and read that list, it's 4 pages long, everything from your teeth turning green to your hair falling out is going to be on that list as can occur. So when you look at the oxaloplatin list, way down here in the bottom is interstitial lung disease. You got that? Pull this next thing up here. Ray's a scientist, right? He loves to do research. A model to assess acute and delayed lung toxicity of oxaloplatin during in vivo lung perfusion. Now this means that somebody is getting ready to give some in vivo. They're getting ready to give some experimental animal, not a person. You can pull that down. A lot of oxaloplatin in the pulmonary artery to see how much it takes to hurt the lungs. And this was about 300 or 400, what you're going to experiment on? Mice, okay? It took a tremendous dose of oxaloplatin to cause any kind of reaction in these mice immediately, and then they didn't sacrifice the mice. They kept them around till they got old. And what percentage of them had any major disease at the time they died was not high until you got to a level of the drug that they gave them that's like 100 times more than you would be giving somebody for chemotherapy. So show this next one. This may be what this guy's CT looked like when he was sick, because this is pneumonia. You know, that stuff's supposed to all be black there, and a lot of it's white, right? Pull that down. Here is what, there is a I was getting ready to go over it, but there's a well-written study when you see a thing that says lung toxicity from oxaloplatin, 2 case reports. Tens of thousands of people are getting oxaloplatin, and when the scientific journal is going to publish 2, is it rare?
It's pretty rare.
It's pretty darn rare. Okay, so we'll stop right there for a minute.
Well, I mean, Bill, one of the things that strikes me about this question is that when you have a patient that's on chemotherapy, you watch their white blood count.
Right.
You watch them for immune suppression.
Right.
And you tell them you get symptoms of fever, cough, congestion, bladder pain, diarrhea.
Well, it was bladder we did a few weeks ago, wasn't it?
Call me.
Yeah.
Call me, because I'm watching you for this. The primary care who has a cancer patient says, I need to treat infections quickly. I got to diagnose them quickly. So, I mean, it happens with patients that are on treatment.
Right, and this guy had a high white count.
And he had a high white count and a cough, and he was short of breath.
Yeah.
So, I mean, it's just to put down the therapy that the patient's receiving is obnoxious.
All right, so now we're going to go. I'm going to do this without videos. I told you I pulled a punch out. I'm going to do this. I'm going to talk through this. Okay, so he has had 4 months of this treatment, has responded dramatically well to it. Well, when we sit in here before, we're talking frequently about trying to get somebody to the point where they've had maximum response and you could do the surgery to remove it, or they've had maximum response and you can pull some drugs out to try and maintain that response. So this is actually the spot, 4 months, where in colon cancer or lung cancer you go and look at, can I pull out the drugs that are giving him the most trouble and use fewer drugs to maintain his remission? So my thought is, one, the oncologist at this point in time was going to make this kind of decision anyway. There's no reason for him not to pull the oxaloplatin out because he's got other choices. Show that next thing here. We haven't talked about Avastin in a long time, but you remember we've talked about Avastin here before. This drug has got to be safe. Pull it down now. I will show something in a minute. It's got to be safe because Ray takes care of people in a retirement home. I'll bet you 20% of the patients in that retirement home are seeing an ophthalmologist who is injecting a drug into their eyes to preserve their vision because they have retinal proliferation of blood vessels. It's very common, and it's done in the doctor's office in the country in Blue Ridge. You don't have to go to a retinal specialist in Atlanta anymore. What's that drug? Avastin. All right. So we're going to have one more picture here. It's going to explain what that's all about. Where'd my picture go? No, don't put the picture up. I'm going to go this way first. When a cancer cell goes into the lung or somewhere else to spread, it does not have a blood supply. It creates a chemical, I call it, remember, called VEGF, that makes the blood vessels around it spread a route and send the blood into the cancer cell to feed it. It's just like when you throw a ear of corn into the ground to grow corn. It doesn't have a right side up or an upside down, and when it germinates, some of it goes up as a stalk and some of it goes down as the root because there's genetic things in that cell that tell it to go in the opposite direction. So this drug, Avastin, I'll just put the next one up because it'll show you how complicated it is. This is sort of the algorithm of how that cancer cell secretes this material that makes this little blood vessel over here make a root blood vessel, and it sends it out like a stem or a root. You can pull that down and it get into the cancer cell. So what they're going to do here, and I guarantee you, is they're going to keep on giving the other part of FOLFOX, which is 5-FU. He's going to put Avastin in there, and Daddy's not going to have near as much trouble with his fingers being numb or his blood count being bad, and his disease is going to have good control, and he can have good control if you look at that survival curve going out 5-6 years. Now, he might not, but that is an appropriate treatment, and I would say that the pulmonologist was wrong, that the pulmonary toxicity from oxaloplatin is extremely rare, and it becomes a diagnosis of exclusion. If it's not pneumonia, doesn't clear up, you go through there and make a biopsy, then under the microscope you would see that. But a guy who's sick, coughing up corruption, and 2 weeks later on antibiotics and steroids does not have chemotherapeutic lung toxicity because it doesn't go away with antibiotics in 2 weeks. Your turn, Ray.
Well, I mean, you're right on, and it's good coordination of care that makes the difference.
Thank you, Georgia Cancer Specialist, Northside Hospital Cancer Institute. As they asked on the question, what do you say? And
I say that your oncologist is doing the right thing, and the pulmonary doctor made a mistake. Now, I'm going to say this about Ray. He's got gray hair, and I got gray hair.
Is that what that is?
That is what that is. I had
At
a
least
patient.
it's hair.
I have gray hair. Go ahead.
I had a patient yesterday who comes to see me now from Hilton Head, South Carolina, that used to live here, and says, we just don't find any doctors that'll talk to us. And Ray said back in the earlier discussion, the doctor should have picked up the phone and called and talked to the other doctor. When they say obnoxious, she prefaced that with young. But I will say that I don't believe that doctors that are trained today, one of the things we might talk about in the news is artificial intelligence. But when Ray and I were in medical school, we didn't have all these diagnostic tools that utilize high-tech instruments and algorithms to make a diagnosis. We had to listen to the heart or do a rectal exam and test the stool for blood, do a barium minimum, look at, I mean, it was a lot more primitive, but it meant that you spent more time with the patient, talking to the patient, examining the patient, and having intercourse and interfacing with the patient. And these young guys are algorithm guys. I guarantee you that when he saw this patient and his nurse put in the drugs, his algorithm pulled up lung and toxicity from oxaloplatin, and he linked the two without going to figure out, does it occur very often? And it didn't.
Well, Bill, the thing that scares me about what you're saying is that collaboration with other physicians is the most important way that we get smarter in our careers.
Yeah, it's dead.
Absolutely.
It's dead. It's dead and dying.
Going and reading a book and going and looking at a chart and thinking you're doing a job on the internet without collaborating and getting other people's points of view and listening carefully and discussing and pushing back and forth, that's where we learn.
Yeah, Dr. Google doesn't
I like that,
talk to
pushing
you.
back and forth.
Yeah.
I like that. I love medical, whatever. I love when the discussion, you get a group of people and you push back and forth and you see, but that's why I inserted that early on in this question when I asked that, of communicating.
Well, Dr. Google doesn't treat patients.
No. Neither does Dr. Fauci. Pardon for the the slam.
You got a Fauci in there.
We're not finished. MD, PhDs, and Masters of Public Health, I think, are harming much of medicine. Now, some of them are greatly benefiting it when they're getting malaria treatment out to where it belongs and getting HIV drugs out in Africa and stuff. But if you give a doctor a Master of Public Health, then he doesn't become a doctor anymore. He becomes a bureaucrat, and his mindset changes. Is that right?
And they have their use. I don't want to put down.
I did. I
totally.
said it got malaria cured.
But and it's not just medicine. It speaks to our whole philosophical culture. Okay, are we listening to people, and are we talking and working things out, or are we telling people, "I'm the authority. This is what you have to do"? And we've gone through 2 years of this, and it needs to go away now.
Well, I'm not telling them that. Somebody else may.
Well,
I always say we're treating a human being and not a chart. Okay.
Not a chart.
Our second question, and while we're on the second one, keep an eye on the sun. Is it turning us dark already? It is. Okay, I forgot about that. So in our next segment, we may move. Power through the beer truck?
Oh, I've been heard over the beer truck.
Okay.
All right, now this one is a BKP question, and we've talked about this before. We're not violating a confidence. My father is 78 and a miracle. 4.5 years ago, you discussed his advanced diffuse large cell lymphoma, which destroyed thigh bone, and no surgeon would operate on him. Do you remember that? We were here. That was 4 years ago, 4.5 years ago. He was treated, as you suggested, with CHOP-R for 6 months. And over 18 months, his thigh bone healed. And that leg is 2 inches shorter than the other. But he made an elevated shoe thing himself and has normal activity. Now, got that? So he had a leg length discrepancy, and he must have been a country boy, so instead of driving to Atlanta or somewhere to get a orthopedist and expensive people to make him an elevated shoe, he went out to a workshop and made his own, okay? That's what that tells me. This guy here is good with his hands. Now, and he has normal activity. And the next thing they says, all his friends are dead, and all of his Simlics have advanced Alzheimer's. So suddenly you can see he's really self-sufficient. He's cured of this disease, really. And he's taken care of the limitation he got from the busted up leg. So now we're moving into something else. 2 years ago, he had a Clark's 3 melanoma. Now, that's not advanced. I've got one of those. I go back to the dermatologist. And he has stopped going to the doctor because he can't drive and no one near him can help him with this. So I guess the dermatologist wants to see him because it's 2 years, but he's not going to find much. So that's my feeling. I live in Europe, and he lives in North Carolina, so he must be across the border over here. His oncologist now sees him every 6 months and checks most things, and his church drives him to those appointments. You know what that says? Back when he was getting treated and didn't have much support, the cancer center he was going to had one of those community relationship things, and there must be a group of churches near where he lives that drive the elderly to that's a great thing that happens in the country. I don't think you see this in downtown Atlanta. His oncologist now sees him every 6 months. His church drives him to those appointments. What do you suggest we do? It's an interesting question, isn't it? Yeah. What do you suggest we do? Well, I'm going to say, first of all, the guy's a miracle. You've already put it. Your mother, it's 5 years or something, with diffuse large B-cell lymphoma. She didn't get any broken legs. All right, so put this next one up. This will be quick. We're talking about this disease we've talked about a million times. Diffuse large B-cell lymphoma. This was the kiss of death until the drug Rituxan was invented.
Right.
All right. Now, this guy had stage 4 disease. We'll go through this again. Most people with this disease have stage 4 disease, meaning that it's generally everywhere. But if it's invading a bone, that's stage 4 by definition. Now, what do you got there is
That's a survival curve.
all right, the bottom survival curve is the survival curve of this disease treated with CHOP.
Mm-hmm.
All 4 of those survival curves above are the survival curves treated with CHOP R. So once you added R, that's stage 1, 2, 3, and 4 right there. So they've all got virtually the same survival once you added that fancy drug Rituxan. Remember?
I remember Rituxan very
now,
well.
Rituxan is harmless, human antibody, directed to a genetic change on the cell. Guy was magic. Show the next one. Here is a CT scan, an X-ray made of the guy, and this is a patient's got to look just like this one, who on his X-ray, you can't really, there's no fracture there. There's a little bit of a light spot there, and he must have coughed or sneezed, and you see how that thing just broke like a green stick? Pull that down. I've had 2 hip replacements. When you do a hip replacement, you take out that bone right there, and you put metal in there. And what did she say here? No orthopedist would operate on him. Well, no orthopedist would operate on him because the operation would have been extremely hazardous. It would have interfered with him getting treated. And as long as they stabilized that leg some kind of way, so they probably put him in a cast or a brace, and he probably had to walk on crutches, then there wasn't any surgical procedure that had a benefit that exceeded the hazard. And 18 months it took for that bone to knit itself, and it was significantly damaged, so it got shortened by 2 inches. Now, what we would generally do is we'd say, okay, there's an orthopedic brace company in Atlanta. That's the closest one. There's not even one in Savannah. And they are in the business of making these prosthetic shoes. You go down there for $800 or $1,000, they're going to make you a shoe. And this guy went out to barn somewhere and fixed it himself. So I'm real proud of your dad here. And I would tell you, I think that he ought to stick with going every 6 months. Let the church take him and forget about going back to the dermatologist at some other interval. And if the oncologist sees something, he'll get taken care of. And don't worry about your dad. He seems to be able to take care of himself.
And I would ask that they check with their primary care physician about getting his bone health attended to. There are ways of making bone stronger.
Yeah, I got the sense that he's got to be pretty rural here.
They may not have a doctor that does that.
She does not mention that at all.
Yeah.
And she also mentions that she's in Europe, so she's
so she's remote.
She lives in Europe, so
Yeah.
she's got a little bit of a guilt thing that Dad's there. You know,
Yeah.
I mean that's the way it looks to me. But I'm real happy with the way the people in that community have gathered around him, and we do have relationships with community church groups or other groups, I mean, the Kiwanis or whatever, that do take care of this sort of thing for the elderly and the lonely.
Yes.
All right, again, thank you very much, Georgia Cancer Specialist affiliated with Northside Hospital Cancer Institute. Now, you have some news of the day. We're waiting for
we got
one more in the All-Star panel.
We got lots more stuff here. First of all,
lots more stuff.
All right, so today, what's the big news of today if you're watching CNN or something else?
That'd be only a couple people.
Right.
It's probably baby
so those
formula.
three people
Those
are
three people.
those three. We're going to say
formula.
three.
It's not baby formula.
It's not baby formula.
No, it's a epic day in America today. This day, 1 million COVID deaths today.
So-called.
So-called.
I'm just getting to that point.
Interesting.
How many? What's the moving average of COVID deaths in Blue Ridge, Georgia, per week?
Zero.
How many have we actually had? One. But we've had one in the last 3 weeks, so that still keeps the average for the week. So there has been one. It was 159, remember? Now it's 160.
Okay, so
But I don't know whether that one died a week and a half ago or what, but it keeps the average at zero.
I guess here's a question I have.
All right.
Okay. Is the overall, and I'm not being insensitive, I promise, is the overall death rate up?
No.
Death rate? No, it's way down. The overall death rate.
The overall death rate.
From COVID?
No.
All cause.
Yeah, yes. All cause mortality went up. It definitely went up a lot.
All right. Okay.
Okay, it went up a ton.
All right.
All right, but I'm getting one more. We're getting one more place. 12.7% is the positive test rate for this week. For this week.
In Georgia.
In Georgia. So the point I'm making is, they have at least gotten to the point where a positive test is not a case. Now, how long did it take them to get there?
Forever.
2.5 years. 2.5 years. 2.5 years took them to get to that point.
Okay, now let me ask this.
Well, first of all, do you understand the nuance that we're pointing to here?
No, I don't.
A positive test is not a case. Okay. In medicine, we treat people. And people can have abnormal labs, and one abnormal lab doesn't mean they have a disease. They have an abnormal lab or an abnormal finding. A disease, a case, is a set of symptoms and signs that make up that diagnosis. The fact that the CDC said, well, this positive test means you have COVID was BS from the beginning. 2.5 years later, they're finally backing off and saying, well, it's a positive test. Because it is endemic, not pandemic.
75% of the ambulatory population had the Omicron virus.
Yeah.
And 56 to 60% of the unvaccinated people that are up and around like us have the antibody.
Yeah.
So if you said that, then the number of cases would be 200 million.
Yeah.
It'd be 2/3 of the population of the country. So that
blows the number away.
It was fallacious. It's fallacious at the start. So that was one thing. Now you mentioned the formula.
Yes.
Okay, I mentioned it, and this is the same thing. I mentioned about the oxaloplatin, that they had to search worldwide to find 2 cases of this lung disease when 1 million people have had the drug. So that means it doesn't happen very often. Truth of the matter is, and I had Wade just go over this with me, truth of the matter is that there were 3 infants who had a bacterial illness who have had Abbott's formula, regular formula, and the FDA shut them down such that they stopped you're not making just the regular formula, but all of the specialty formulas that you've really got to have if you've got an infant with small bowel obstructive disease or kidney failure or diabetes. You have to have a specialty formula.
Well, let me emphasize that. Let me put a common sense on this. When a mother decides to not breastfeed, the baby is on formula, and there's no backing up. For a government agency which is controlling only 3 manufacturers of baby formula to shut down one of those manufacturers and not expect problems,
the biggest one,
is ludicrous. It's dumb.
All right, let me ask a question. So the FDA shut this plant down in Michigan.
Yeah.
Okay, my understanding it's the largest producing plant in the United States.
Yeah.
So let me ask this question. I understand when you get in these behemoth bureaucracies, you know, things move slow. But if you're in the FDA, let me paint the scenario, and you say, look, we have two we have two deaths that we feel are related to a bacteria that may have come from this baby food plant. Let's leave it there. So we know you're in the conference room, and you say, we know if we take this thing down, we've got X amount of weeks before this affects the national chain and the shelves in the grocery.
You're getting ahead of yourself.
Let me finish. I want to finish.
They're going to pull it off the shelf.
Wait a minute. No, right? So so here's what we got to do. We got to send the whole team in, because this is code red. We got 2 weeks to identify, figure out, correct it, and get these machines running, or we cause a crisis in the country.
But Brian, you're attributing more intelligence there than's being shown.
No, I'm serious. Where am I? Well, I
you're
mean,
not wrong.
At what day does the FDA say, oh, maybe we should get this back up? Because I read a report. This thing's been down for how long now?
Well, what number? It's worse than that.
Okay.
England has had baby food shortages for a month ago.
Yeah, 6
and
weeks, I think.
And we're not paying attention to what went wrong there. Okay? So we already have an example in the world of how bad it can be.
Right.
It is the proper job of the FDA to find a problem, identify where it is, and go in and make changes or make precautions. That's their job. Not to go in and assume that we can do things that have all these downstream effects that we don't have to pay attention to.
All right, now stop here just a minute. Do you remember the peanut butter plant in South
Absolutely,
Florida?
absolutely.
Okay, now they went in there, and every daggum peanut butter in there had that bacteria in it, right? And that was because there was a moldy pipe up above, and the mold had gotten inside the plant. All right, now they go out to the Abbott plant and they test all the formula in the plant. None of it has this bacteria.
Exactly. In the article I read.
I'm not finished yet.
Okay, go ahead.
Now they go in the store and they take it off the shelf and they test it, and none of them have it in
right.
there. Now in the closet or the bathroom or the garage of that plant, they can find this very rare bacteria.
Not even the one that's affecting the formula that the kids have.
It's the same type.
Yeah.
But genetic testing of the one that's in the garage out there in that plant is not the genetic strain that was in those kids had. So
they should have stopped.
True and unrelated. They should have stopped right there. Now the second thing that they did, which I think is ludicrous, is if it's in. If you got a big company like Nabisco or something, they make Oreos, and it's in the Oreos. There's no sense in stopping them from making Fig Newtons. So when they stopped making that common formula, they never should have stopped making those specialty formulas that really, because the common formula, my mama went to the grocery store, got a bottle of milk and warmed it up, put it in the thing, and threw some Karo syrup in it. You can make something.
Is it warm? Test it.
But you can make something for the average kid. But you can't make something at home for those kids that have got these specialty needs. It's got to be pharmaceutically made, period.
Here, I remember very clearly the peanut bacteria. I remember that, but that caused us for 2 weeks to have a little struggle in making a peanut butter and jelly sandwich, okay? And that was the extent of that, okay?
But it was real.
Right, you're exactly right. But what I'm saying here is I mean, the shelves are empty in multiple states. In fact, people are traveling from states. I heard a story yesterday, I don't know, one of the big boxes down in Canton, nothing on the shelf yesterday. People are traveling from other states to buy it. So I won't get into the political side, but I don't know. I think Americans, like I just said, hey, we got to go on this baby food, the formula plant. We got to identify this. We got to take the ramp-up team, whatever the FDA's got to come up with a ramp-up team. We've got 48 hours to identify, 48 hours to clean it up, and 48 hours to get it back online.
Yeah,
or we got a problem, and these are babies. I don't know. Did I overthink that? Or?
Once you shut down an automobile plant because you don't have you don't have the little chips and then all of a sudden you get chips, it takes them a month to get it back up again, right?
Yeah.
It's going to take, from the day they turn the lights on,
Exactly.
it's going to take them 14 days.
That's what
to
I read.
have the
Yes, I read that in an
infrastructure
article
to
yesterday.
Make it, and it'll be another week after that before they have product. So if you turn lights on today, it's still 3 more weeks.
Really quick, before we do have to get out. Now, when a mother starts, if they don't start at birth breastfeeding, they can't switch.
Once you stop breastfeeding, you stop making breast milk.
Right. If you don't start when you can't come back at it a month later.
And if you breastfeed for a while and you stop and go to formula, it's done. You're done breastfeeding. You don't. There's no backing up.
Okay.
So,
All right, now I don't know that, but I've seen
Well,
some things that I know you just told
Okay.
me.
Well, now wait a minute. You're too old to remember wet nurses. I mean, too young.
Too young. Okay. Let's go with the too young.
In my youth, there were wet nurses, and you could hire a wet nurse.
I've heard these stories.
If the mother could not produce milk, and that was in the days before we had pasteurization, and then whole milk could have tuberculosis in it.
Right.
And many women could nurse for 10 years, and they would nurse for a fee, but they could never stop. Once they were nursing and this baby got off of it, they got to have another one, or they got to quit.
All right, I got to get you to work, so what else do you have?
Well, you got to look at 2 things here. Now, that one right there, I don't know how good your glasses are.
I forgot them today.
U.S. drug overdose deaths top 100,000 for the first time. Ray's been on this. He's been harping on this. You talk about 1 million COVID deaths. When you got 100 fentanyl deaths of young teenage guys who were smoking pot that was laced with fentanyl and stuff, that's a blank tragedy. And every one of those came across the southern border, and they impounded last week in one shipment enough fentanyl to kill 100% of the Americans. 350 million people could have been killed by the amount of fentanyl in that one truck. And that came across the border last week. So if you don't shut down that border, this is going to get worse.
The visual that I think is stunning is the amount of fentanyl in the amount of a sweetener pack, the little pack you put in your coffee, is enough to kill thousands of people. Thousands.
That's if they haven't cut it with milk
straight
powder.
fentanyl in that small of a quantity is potent enough to kill thousands.
Now, when it gets on the street, they've got it cut with pounds of baking powder and everything else to make it more. But that fentanyl will kill you. That's all you need to know about that.
The All-Star panel blames me for doing all the talking.
Well, she just got here, so.
Okay. Yeah, okay. What do you have? You have a closer?
No, I'm good.
You good?
Well, yeah, I'm good. I thought we were going to hear the joke.
Well, okay, so anyhow, we'll supplement what I have to say for the joke. The next time you need a gray hair example, you have my full permission to refer to me. The next time you need to do anything...
Well, we're both going to the same barber that's putting these strands in our hair, right?
Yeah, because you know...
I'm going to get a weave next week. Huh?
You know, there's one thing I know absolutely nothing about. One thing I know nothing about. You know what it is?
Bald.
No. You know what it is? I know nothing about a bad hair day. Okay, folks, we'll be on my worst day. I know nothing about a bad.
Let me close with this.
I knew now
what
he's
was
got
John Lennon's last 2 words?
I don't know.
Uh-oh, Yoko.
Uh-oh, Yoko. All right, folks, we'll be right back with the All-Star Political Panel right after this. Thank you, Dr. William Whaley, Dr. Raymond Tidman, and especially Georgia Cancer Specialist, Northside Hospital Cancer Institute. We'll be right back.